I've got to say, it's really exciting for me to be giving a talk that doesn't involve transplant. And I want to thank my colleague, Dr. Danny Hawkinson, for finding some really cool pictures of some of the robotics and helping me put this talk together. And one of them is this, that initially the very first medical surgical robot was developed by NASA. It was explored by NASA and performed a surgery, cholecystectomy in 2001. And the first surgical robot was called the Puma 560, used in 1985 for brain biopsies when they were doing a lot of stereotactic brain work and neurosurgery in the OR. And then there was the Probot that I never got to see during my urology training, but would have loved to play with for transurethral resection of the prostate. And then Robodoc, which sometimes we feel like we are when we're doing these cool robots. And then three platforms emerged early on in robotics. And the one that you're going to hear the most about, the one that we're most familiar with that is captured the market right now, is the Vinci system by Intuitive Surgical, but also there was the ASOP and the Zeus. As you heard from Dr. Cha earlier, minimally invasive surgery has been employed and is a big deal in all kinds of general surgery, but has been used in hepatobiliary and pancreatic surgery for some time now. There's been numerous studies that support liver resection with minimally invasive techniques. They found that in skilled hands that there is less intraoperative blood loss, there are fewer complications, and less postoperative pain, lower lengths of stays as the primary drivers for this, with an initial and 5-year outcomes for primary hepatocellular carcinoma as well as colorectal carcinoma as being very equivocal to the open surgery in skilled hands. According to the recent International Consensus Conference on Laparoscopic Liver Resection, minimally invasive surgery for minor liver resections is now considered standard of care at most major cancer centers. And I think across the United States, and including in our center, as you saw from Dr. Cha's experience, the expectation for parenchymal preserving hepatic surgery is through minimally invasive surgery, if at all possible. And again, as we've been hearing as the theme throughout this conference, it's all multimodality. How do we help each other to complete different types of therapies and give the best therapy to the patients? Major hepatectomy is still being developed and is innovative, still considered, and is done by those with a lot of experience, but the value of the major hepatectomy is still yet to be performed, and this is hot off of this consensus conference from last year, with the major risks being bleeding during the parenchymal transection or during the hilar dissection. If we look at robotics and how robotics fits in, we find that basically the main features of what the robot brings to minimally invasive surgery are improved 3D magnified visualization. To visualize through the robotic lens is phenomenal. It definitely takes that virtual reality type of experience with 3 dimensions into the real field, and those that perform open surgery have a very quick adaptation to the robot in a much shorter period of time of the learning curve than those in minimally invasive laparoscopic surgery, where there's quite a big learning curve to develop for learning the skills of robots. And I liken it to, and apologize, Chuck, if I misrepresent this, but I liken it to learning to eat with chopsticks. It takes some skill and some practice and some time to be really facile at it, while a very skilled open surgeon has a much easier time with the robot and learning how to adapt to the robot because many of the moves are the same. Fine dissection, therefore, is very nice with the robot, especially with some of the new tools that we have. Parenchymal suturing is also very easy and available in robotics, making it easier for things like biliary anastomoses. And finally, you get to sit down at a console, and so when you compare standing up, standing next to the patient in laparoscopic surgery, there is a measurable decrease in surgeon fatigue. So if you look at the experience in the United States over the last few years, and this is just throughout 2012, you can see that there's been this huge growth in the number of robotic cases that are done, and this being the experience internationally, which is also growing, most of the training coming from the centers in the United States. And as I mentioned before, the Da Vinci system is the one that we're most familiar with, and it's the one at Yale that we've been working towards an affiliation to try increasing expansion of education for our surgical trainees, the residents, to have very in-depth training with robotics. And we've seen this evolution in the types of robots, starting from the original Da Vinci robot, moving through the SI, and then to the XI platform. And we see robotics moving from what initially early adopters were in urology, GYN, oncology, and some general surgery, to adding colorectal, thoracic. Now we've got hepatobiliary, ENT, cardiac, where we're very active, and we have a very aggressive program with cardiac. And even, as you're going to see, with Dr. Hawkinson's help, we're going to be introducing robotic kidney transplants at Yale. The intuitive system had the X. These are the state-of-the-art instruments. This is the X. As you can see, it has 4 arms. There are double joint articulations. This is the single site robot here, which is also one of the latest, and this is the XI, which we already have 3 of, and these are all the state-of-the-art. The difference with the XI and the X I'll show you in a moment, but basically the robot comes with those tools that you saw, what we call the patient cart, the actual robot itself, the surgeon console, and then there's what's called the vision cart, which is where all the equipment lies for both visualization and for the various applications of thermal energy and other technologies. What's been developing over the past several years, in addition to some enhancements with the robots themselves, are the instrumentation. And as you'll see, they have multi-articulations at various joints with the instruments, different kinds of graspers. There's now robotic staplers and robotic energy application devices that use energy like hyperthermia, like we see with a ligature, in addition to harmonics, and then, of course, the 3D high-definition visualization. As you can see, we've got a lot of different tools, and some of which, this is the older SI, which is what I learned on initially, which is, as you can see, has 3 joints, and we get a 4th joint with the XI machine, which is the state-of-the-art. And what we see here in the single port system is you're looking at entry with 1 tube, which then looks like Spider-Man's alter enemy, the Doc Ock, where you can see the scope actually angles out away, and then you have 2 or 3 working instruments and tools to actually do your dissection. And you can imagine putting something like this into a small orifice, from above, from below, and doing intraluminal surgery, or furthermore, as we're seeing with ENT in our team, with ENT doing thyroid, parathyroid surgeries with a very small incision, and that's really cool. And if you see that, you look at the way that this service and this technology has been exploding, it's coupled with quite an immense amount of education and training with a lot of simulation. And so they have these programs and platforms now that are called SimNow, and it even tracks on your phone so that trainees, young surgeons learning this technology, and the trainees that are learning this technology can spend hours at the on the sim consoles, but also on their computers, learning all types of different formulations so that they can literally practice surgeries even before performing them with high similarities. And so it's been an amazing opportunity for us to collaborate with this technology. So far for liver and biliary surgeries, the major advantage for robotics is in cyst fenestration. Robotics does give us an opportunity in major lobectomies, especially when you talk about superior sectoral tumors or posterior sectoral tumors compared to laparoscopic approaches. And it seems to be a favorable approach in cirrhotics, especially with parenchymal preservation. That seems to be the trend. Any kinds of bile duct injuries, repairs, reconstructions seem to be a really good event for the robot, as well as when we look at performing suturing, such as the Roux-en-Y hepatico-J genostomies. That seems to fit very well. This paper looked at where we were comparing the studies, some of the later studies comparing laparoscopic hepatobiliary surgery with robotic hepatobiliary surgery, and again showed the themes that I mentioned, that although the robotic surgeons tended to perform what's called a Pringle maneuver, where there's a band to compress the inflow of the liver during the resection more often than they did laparoscopically, overall the robot seemed to do pretty well compared to laparoscopic liver resections, with perhaps some superiority for the superior and posterior segmental resections over what was done with the lap. But the time in general spent in the OR with the robot was longer than with a laparoscopy, and blood loss and conversion to open depended on what studies that you looked at as to looking at superiority. So overall, it's about the same, but robotics tended to take a little more time, but they did tend to have some advantages with the cirrhotics, the posterior and superior tumors. When you look at this paper that came from the Sloan Kettering group, and you can see that the data shows non-inferiority, as I mentioned, with a steep learning curve but less than laparoscopy, the possible advantage, as I mentioned, with the posterior and superior tumors, and that the length of stay and comparable morbidity, mortality, the cost, blood loss, and oncologic outcomes are all being evaluated right now, and are, depending on what studies you look at, sometimes the robot has increased cost, but the more it's utilized, the lower these costs are becoming. And also the choice of how many staples you use, which stapler, and other instruments have a cost effect in those studies. In general, doing things that we can do very well and efficiently laparoscopically are not necessarily advisable robotically, and I think Dr. Cha would agree with me on that, that for things like cholecystectomies, doing robotic cholecystectomies are not superior in any way. I think that we definitely have to focus on the things that the robot may do very well, which involve, parenchymal preservation and difficult to access tumors. And I'm going to show you some of our experience here in a moment. And the opportunities for common bile duct explorations and repair of common bile duct injuries with suturing certainly is something the robot can afford us fairly easily. This is what we look at when we're trying to set up a robotic case. As you can see, we have these 4 arms. They're numbered, they're multi-jointed, and we have a template that we apply for the patient in general with these new XI platforms that are fairly linear, and we apply an assistant port, and it depends on the case that you're going to do, where the target is that you're going to look at. You can adjust this template, but the newer robot now is a little bit closer and applies a horizontal template, and and the XI, differentiating from the X, allows a table integration. If you pay the extra money to have a table that moves with the robot, the XI allows all that to take place, whereas with the X and some of the earlier models, you have to plan exactly where you want the table to be before you dock the robot and get started with the surgery. You can't make those changes without undocking the robot and moving it out, again, adding a lot of extra time to the case. So we generally have the patient in a reverse Trendelenburg. In general, the recommendation is to bring the cart in from the right, but it can go in from either direction. And as in these examples for upper abdominal surgery, they show the patient flat. My preference is to actually put the patient with their legs spread and have the assistant stand between the legs. I think that gives the assistant a little bit more control. This is a very classic case, which is ideal for the robot. And I think, in my opinion, a little easier to do it robotically than laparoscopically. And that is, here we have a benign 8.5 centimeter hepatic adenoma of the caudate in a young mid-30-year-old diabetic. And she came in with this mass. It's a large caudate lobe mass. And you can see proximity is right behind the portal vein, right on top of the cava, where the caudate lobe expected to be. And we were able to remove this tumor, which is depicted here, and you can see this is on the coronal view, and we were able to remove the tumor through just an extension inferior to the umbilicus with a plate like this on this obese woman. Here's another case where we had an early cirrhotic gentleman that had 2 lesions of hepatocellular carcinoma in his posterior right lobe, and we were able to do a resection there and actually extract it through the assistant port here in what we made a kind of a transverse linear fashion. So robotics definitely have a role, and they're definitely, as you saw in Dr. Chaw's presentation, there's a lot of advantages to minimally invasive surgery for our patients, and I think we'll see this come forward as we go on in time. We'll see that more and more minimally invasive approaches will be coupled with our other modalities of therapy to have the best outcomes for our patients. As you can see here, we have many more robotic and minimally invasive technologies being introduced on the market. Medtronic's just got approval for a new robotic system that they're bringing forward, and there's a few more, including one coming from Google. And I think that we're going to see a very competitive market going forward in the future. So in summary, I'd like to say that using or considering robotic assistance with surgery and resection for liver tumors and biliary tumors, does give an advantage. The advantages are for the 3D magnified vision, the improved ergonomics for the surgeon. Generally, there's the same dexterity as I mentioned with open surgery, and one doesn't have the training and skill development that you need to really be an excellent laparoscopic surgeon. It does enable delicate dissection. There is a question of haptic feedback, which can be difficult, and it takes some time to learn as far as knowing how tightly you're squeezing. They're developing technology within the robot that is actually going to simulate that, but that's still under development. But overall, the ability to do robotic surgery brings us, into incredible opportunities for access all over the body, and hepatobiliary surgery is certainly one of those areas that can benefit. So thank you very much. We'll look forward to further discussions of the panel.